in exam, but it's good to see this drawings and illustration about the bone. So you should consider the patella as one of the sesamoid bone. Ensure that you know that this is the metaphysis, the growth plate, and the epiphysis, and this is what is called apophysis, and finally diaphysis. Yes. And let's shift to the next. And here, sure that you know from basic principle that this is the cortex and this is the medulla. And you can see that what is called the trabecular pattern. Yes, this is the normal. And when you describe some descriptive that this is the head of the metacarpal, or if you are in the foot, it is the metatarsal, and the neck and shaft and the base. And we saw many examples how, for example, the base fracture or shaft fracture with or stress fracture in the shaft, neck fracture and head fracture. And here the distal articular surface, and here the proximal articular surface. Yeah, in the knee again, the site of meniscus will be here, and the cartilage, the joint space, and the soft tissue of the joint capsule. So it's good to know that, for example, here in this patient, that he have what is called malalignment, as you see here. So sometimes it will be the abnormality with acute trauma, not just the fractures. And sometimes the abnormality could come to you as loss of joint space with narrowing and osteophyte formation, as in any regular osteoarthritis. And when you check the fractures, as we saw in the rapid reporting, that you should go through the cortex to check if there is any fracture line. So here, when you reach this bone, you will find that there is lucency in this area interrupting the cortex. Okay. And when you check the femur, for example, here, you should check for the trabecular pattern. So this is the normal trabecular pattern. And any distortion in the trabecular pattern, it will make this abnormality, when it is present, very obvious. Okay, so this is like introduction. And for example, here in the knee, it's good to check for something like the fat fluid level, which is sometimes subtle, and give you impression about what is called lipohemoarthrosis. When you find, for example, the fat, which is the black lucency, and the blood. Yes. And here you will search for tibial plateau fracture, as we see in the rapid reporting before. Yes. And it's very important to check for the two views. So not just one view. You should, for example, here maybe you can see it, but here it's very obvious that it is clear. And when you check here in the pelvis, you compare between both sides. Sometimes the both sides are affected, but if you are lucky like here, and like a fractured neck of femur, usually it comes unilateral. So you will find it in one side with the lucency interrupting. Yeah. So the comparison sometimes is very useful for fractured neck of femur at this case. And I want to show you something here. So if you look in this case, do you see any abnormality? Nirmin, welcome. Yes. Do you see any abnormality? Yeah, there is one lytic lesion here. That's true. And it's very nice that when you compare it with the previous image, as in this case, then when you see the fracture, you will know the cause of the fracture, that it was lytic lesion. So maybe there it was subtle in the previous X-ray, but when you saw it in the new X-ray and you see the fracture, then you can know the cause. So it's nice if you, for example, if you find this, you compare with previous studies. And here, what do you think about this one? Okay. Still bad resolution, or yeah, maybe the internet today is not very clear, but I wish it can be improved with the time. So what do you see in this abnormality? Okay, perfect. So here, this is the fibroid or uterine fibroid with calcification, which sometimes can make you satisfaction, but the patient already have, yes, fractured neck of femur, so you should check for something unexpected. Okay. And this one, I think I show you the answer. So already, maybe you will describe here, maybe something related to the impingement or the shoulder impingement. But look in this region that already the patient have apical mass. So you should check carefully, because maybe sometimes they show you in the field, especially in the FRCR, they like this type of cases. Yes. Okay. For example, here, let's have a look. I think this one is easy one. So you know that the inferior surface of the clavicle and the acromion should be in the same alignment. So if they are not in same alignment, as we saw it in rapid reporting before, so this is what is called acromioclavicular joint disruption. And also you can see that the distance between the clavicle and the coracoid, the cracoclavicular distance, is very wide. So this means that maybe this is ligamentous injury as well, right? Okay, we saw already these cases, so for you it will be like some revision, but it's important, yes. And you remember when you talk about the shoulder dislocation, so the normal alignment between the humeral head and the glenoid should be like this, in the same level. And they like to show you this, what is called Y view, like this Y view. So when you look in the Y view, the humeral head should be in good alignment, and the glenoid yes, posterior to the coracoid. So the coracoid should be anterior, and the glenoid should be in more posterior position. And here should be the humeral head. You can consider that the humeral head should be near the center of this Y. Okay? This is the normal. And they like to show you this view, the axial view, then to recognize the glenohumeral joint, the coracoid, and again anteriorly, and the acromion posteriorly. Okay, and the acromioclavicular joint should be here. Yes. So this is the normal for the axial view. So now the time to describe what is here. Yeah, anterior shoulder dislocation, Ermin, thank you. So you can see that the alignment between the glenoid and the humeral head are disrupted. So the humeral head lie inferiorly, okay? Or you can consider it below the level of coracoid, yes. So when you find it like this means that there is anterior shoulder dislocation. And let's have a look in this one. So you remember when we talk about the normal, right? Just a few seconds before. So what happened here in this anterior shoulder dislocation? What is the abnormality? The humeral head position should be at the level of coracoid. So what happened here? The humeral head should be here, but now it go inferiorly to the coracoid process, right? I think that maybe you would like to go to the normal to check it again, right? I feel it. So let's check it again. So the normal, if you remember, it was the humeral head almost in the level of coracoid process. So when it go in inferior position, so this means that what is called shoulder dislocation, anterior shoulder dislocation. In the EB will be like this, and in the
استنى ما تتكلميش مش فاهم.
okay, I'll just make the voice. Okay, and here it will be in the inferior location, okay, to the coracoid process. Is it clear for you now? And finally, the axial view, which is the most difficult one. The most important to know where is anterior from posterior. So if you remember, we tell you that the humeral head should be at the same level with the glenoid. So the humeral head should be at the same level of glenoid. So what happened here? That the humeral head, it lie anterior to the glenoid. So again, anterior shoulder dislocation. So let's check again the normal to remember it, to remember together maybe. Let's have a look. So remember again that the humeral head should be at the same level of glenoid. Yeah, the alignment. Dr. Ahmed Fathi, can you close the camera, please? Thank you. So it will be in the same level of glenohumeral articulation. Okay. And here, if you go and check again, now you can recognize the abnormality that the humeral head anterior in position. Okay. Okay. Now time to okay, just make like this. Okay, time to see where is the abnormality. The history in this case, it will be sometimes it's important, especially in the viva, that they like maybe to give you like history of what? Do you know? Yeah, this is what is called posterior shoulder dislocation. But when we give you the history, it will be history of epileptic fits or epilepsy. Nice. So you can imagine that this patient sometimes have bilateral posterior shoulder dislocation. And this is what is called light bulb sign. So let's try to describe what happened here. So the glenohumeral joint, as you see here, is widened. So not any light bulb for you, it will be sometimes you can see, you can imagine that it can be light bulb, but what is not light bulb sign. When you see some cortical irregularities of the humeral head, maybe there is some impaction fracture. Okay, so this is what is called posterior shoulder dislocation. Yes. Again, in the Y view, now the coracoid anterior, if you remember. So what happened here that the humeral head go in the posterior direction. Yes. So it should be in this area. If you remember, it should be, you can imagine that the center of the humeral head almost in the center of the Y. But now it go posteriorly. So this is what is called posterior shoulder dislocation. So again, the Y-shaped should be with the glenoid and the humeral head in the same center, almost. But when you see it go posteriorly, so this is what is called posterior shoulder dislocation. Okay? This is very important for the rapid reporting and for the viva cases, and sure for the EDIR. I know that you know the anatomy of the scapula, but okay, maybe just to check that this is the acromion spine, coracoid, this is the superior border, the medial border, the lateral border, scapular body, and the glenoid and the neck of the scapula. Okay, so sometimes the scapular fracture are easy, and in this case, okay, so you can recognize it easy that there is malalignment and there is scapular fracture. Yes. But you remember in the rapid reporting cases I showed before, some of them very subtle. So you should go and check the cortical outline. Okay. And here, what is the abnormality? I know that is for you now is easier because we already saw like much hard cases, but let's just make some brainstorming. Yeah, so fracture glenoid. So where is it exactly? This glenoid. You see like a bony fragment. Yes, bony bankert. So this is what is called bony bankert. Yeah. So this is the glenoid, and you can see that there is disruption of the ring of the glenoid here. And this ring beside, you can see that there is a bony fragment here. So you would like to ask about anterior shoulder dislocation in the history, and sure you will search for health sac injury. Perfect. The humeral head fractures is very easy sometimes, like this case. So you can here see the transverse fracture with surgical neck involvement and the greater tubercle, and you can see the separation. And they like to ask you in the MCQ about what is called NIRS classifications of the humeral head. So 1 fragment, 2 fragment, or 3 or 4, right? Okay. And here also you can see, as I showed you before, that sometimes the cause of fracture you can recognize, you can see it. Like here, it is a lytic lesion in the humeral head, and after that happen some pathological fracture. Yes, Ella. Nice, perfect. And also here, like there is varus angulation. Now we go to the already you saw it in the rapid reporting before many times that the keratoid, capitulum, radial head, internal, trochlea, olecranon. Yes. And sometimes because the last one, the external one, the lateral ossification, so, the epicondyle, lateral epicondyle, so sometimes you cannot see it like here. So it is non-ossified. Yeah. It depends on the age, 1, 3, 5, 7, 9, 11. Okay. And you remember correctly that when you go to the elbow, you start with 2 lines. So the first line, it is the radiocapitular line, and it go from the center of the radius, and it should cut the capitulum. Yes, and the other line is the anterior humeral line. So you check the fat bed sign if there is any posterior fat bed sign. The anterior fat bed sign, you can show it as a normal, but the posterior fat bed sign shouldn't be visible, right? Yes, because the triceps should be with intact position with the humerus. So any separation here, it should be like supracondylar or raised possibility of supracondylar fracture. And the more than 1/3 of the capitulum should be anterior to the anterior humeral line. So this line should at least 1/3 of the capitulum lies anterior to the this line, yes, of the capitulum. Okay. I know for you now, maybe it's easy. We show already the, multiple cases, but okay. Again, the capitulum, radial head, internal, and you can note that the trochlea here is not ossified. Yes. So they like to mention that you should suspect avulsion of the internal or the medial epicondyle if you didn't see it, or if there is any ossification at the site of trochlea. So if, for example, here, if you find the trochlea ossification, then you should go and suspect avulsion of the medial epicondyle. So here, I think we saw it already, but I will show you. Now, for you, it's easy to recognize what is called posterior fat bed sign. Yes. So you can see here the posterior fat bed sign. Perfect. And here you want to show you that already this patient have fracture in the radial head. Perfect. And here, if you go and check, you can see the posterior fat bed sign with the effusion, and you can see the fracture line which traverses the supracondylar region. So be ready, because we will apply now for the rapid reporting. I wish that you will enjoy it after. Okay, and here is easy for you if you apply the radiocapitular line and the anterior humeral line. So the radiocapitular line, it doesn't pass through the capitulum. So this is what is called radial head dislocation. Yeah. So it is dislocated from the elbow. And also you can see that the ulna dislocated from the side of the trochlea, where is it articulate. Okay. And we saw already very subtle cases of radial fractures. So for you, this one, it will be very easy. And they like to say that maybe there is palmar or dorsal angulation. Okay. And to mention also if they reach the articular surface or are being comminuted, like this case. So they like to show you that it can reach the articular surface or comminuted, as in this case. So distal radial fracture with comminution. And you remember the two very common famous fractures in the exams, Monteggia and Gliese. So this one will be one of them. Which one? When you see the ulna is fractured and there is radiocapitular line disrupted, so this means that there is radial head dislocation. So this one will be Monteggia. So proximal ulnar fracture, perfect, and this one it will be Monteggia fracture. And you remember when I show you the fractures of the pediatric age group, and sometimes it's just buckling, as in this case. So just you can see some buckled cortex or mild buckling of the cortex. And you can see also the fractures sometimes. Yes. So this is what is called the green stick fracture. Okay. And sometimes they like to show you this, what is called torus fracture. And they like to differentiate between torus and the green stick, that, for example, this torus, it doesn't have line, but green stick fracture at this one, it have line, like fracture line. So you can saw the fracture line. So this is what is called a green stick fracture, and the other one which don't have line is called torus fracture. So okay. Finally, reach the wrist, and today we'll finish the upper limb. And sure that I know that you know the anatomy, but let's revise. This is a scaphoid, leonate, traquetrum, and pisiform, and the hamate and the hook of hamate. And remember to look in the zigzag line, if you remember last time. So this zigzag line should be preserved, and the hook of hamate should be under this line, and the fourth and fifth metacarpal bases should be above this line, right? Of this line, trapezoid and trapezium. I think is easy for you now. Yes, you already know them. And in the lateral view, the most important, the cup relationship. So this is the leonate, like a cup, and the radius, leonate, radius, and capitate. So this three blue bones, radius, leonate, and capitate, should be in the same line. And here you will search for the traquetral fracture. So that's why when you find, if you remember, the fragment of bone here, this what is called traquetral fracture. And in the anterior portion, you will search for trapezium, trapezoid, which is not common to be fractured, and the pisiform, and sometimes they like to mention that anteriorly you have the pisiform and posteriorly you have the tracheotrium. So if you find the fracture here, most tracheotrial, and if you find the fracture here, it can be pisiform, but is not common to see. Okay. So the most common one, as you know already, just let's show you, which already we saw it many times, the scaphoid fracture. And it have many association. So you should, when you find the scaphoid fracture, you should search for any associated fractures. Don't forget to, the zigzag line here is very obvious as a normal that you should be used to make check. So now for you, it will be easy to recognize the abnormality here. So which abnormality you know now? Okay, I'm sorry that it's a late session tonight, so I know that everyone is sleeping, but okay. Anyway, yeah, this is the tracheotrial fracture. Doc Bob sign, okay, thank you. Doc Bob sign, bobbing, okay. And this one, you remember the alignment. So in this fragment of, yes, the fourth and fifth, and here should be the hamate. So this is the hook of hamate fracture. Okay. Nice. And finally, I like to show you, I show you already case of this, if you remember. So this is what is called teratoma sign, widened scapholunate distance. And finally, for the rest, remember the perilunate and lunate dislocation. For this one, it will be perilunate, as you see the lunate itself in correct position, but what is moved? The capitate. So this means that it is perilunate dislocation, not lunate. Yes. Okay. Then finally, the fingers. So they like to show you that you should check for the fingers, either distal phalanges, middle phalanges, proximal, and metacarpals carefully. And we should also check for the alignment. For example, here between metacarpals and proximal phalanges. And for you, this one will be easy. This is in the base here with fractures, what is called boxer fractures. And the most important to check if it's reaching the intra-articular surface or not for this one. And it's good also to check for the soft tissue. So look in the soft tissue in both sides that give you a clue that the fracture is here. Yes. So when you have fracture here and it is reaching the intra-articular surface, then you can call it. It's important to check if there is any extension in the intra-articular side or not. They like also to show you something in like this, which is called mallet finger injury. Yes, like here, dorsal avulsion of the distal phalanx base, and sure that the soft tissue is affected here. Yes, so this is what is called mallet finger injury. We are about to finish this big introduction today. So I wish that you enjoy it. So now maybe we can take a few cases. I think for you will be better and easier one now. Let's take about 10 cases, then we go to our end of session. Yes. So what do you think about here? I will try to focus on the abnormality to know it easy. No? Time to apply. So now you can see that the capitate is here, leonate is here, radius is here. So no dislocation. Okay, so if you check the cortical outline, let's check here. You can find like lucency that traversing the distal radius. So this means that there is, yeah, distal radial fracture. Perfect. And I don't know if you can say it or not, but I think if you look posteriorly here, can you recognize something going on here? You remember anteriorly, pisiform, trapezoid, yes, trapezium, trapezoid. So posteriorly, what is here? Yes, traquetral, yes. Okay, I see that you are tired, so I will maybe just 1 or 2 cases more and I will finish. Maybe this one we can skip it because it's a bit hard. So this one, pediatric age group. When you go to check the alignment, yeah, buckling, and this is what is called torus fracture. Yeah. So torus fracture again, maybe very subtle, maybe in the, you can saw it in the lateral view, more easy. Thumb fracture. I try to find for you something easier to. Okay, this one I think is good to check the anterior humeral line. Sorry, anterior humeral line, radiocapital line, and here you can see the fracture line traversing the supracondyle fracture. the supracondylar region. So supracondylar fracture. Here is easy for you to detect the posterior fat pad sign. Then go search for the cause. Maybe you can see that there is a fracture line here along the supracondylar region again. So supracondylar fracture line. Sorry for the technical errors for tonight. I wish that you enjoy. It was short session for upper limb and introduction. We make some application for the rapid reporting. And thank you. And we can, inshallah, continue next sessions, more regular lecture, inshallah. See you. Assalamu alaikum.